Hello, folks. This is a Ticker podcast, and it's kind of important. I'm going to play part of a piece here from Dr. Campbell, who has a guest on. This is a man who has treated people who have, long virus interactions, okay? People talk about long COVID, they talk about long vax. There are those who say the entire thing's psychosomatic. I don't buy that. Why? Because we know that people who have had viral infections that are not COVID related have had long-term symptoms. Okay, Epstein-Barr is particularly known for it, but it's not the only example. There are some people who get influenza and have long-term effects from it. So that COVID or any other viral infection could cause this is not unreasonable to believe at all. But I want to play a section of this for you. I'm going to link the entire piece on YouTube in the comments and on the lead article that goes to this. I'm going to put this on Rumble because I'm going places that you probably can't go on YouTube without getting censored. And they've already decided to squash a number of my things over the years, and I really don't feel like having my channel completely canceled. So I won't, but I will put it on Rumble. I think you should listen to this entire thing. If you are contemplating doing any kind of spike detox, okay, for any of those people that are out there selling this stuff to you, and you're thinking, well, maybe I should use it, I think you should listen to this entire presentation before you make that decision. You might change your mind, you might not. But, and again, this is N equals 1, okay? This is one case. So it's not proof of anything beyond the one person. But it is a cautionary tale, and then I want to add some interpretation to it afterwards because it's not sufficient to just cite this or to just watch this. I think we need to talk a little bit about what it means. All right, here we go.
Now, your patients that you're seeing, we've got symptoms here like chest pain, passing out, fatigue, cloudy brain. Can you just tell us, in a sense, describe the suffering and the clinical features that these patients are presenting to you with?
Well, there's a certain commonality. What we discussed the other day was that long COVID has confused to an extent because it's a ragbag diagnosis. It's somebody who has persistent symptoms 3 months after they've had COVID.
Yeah.
And we know that at least two components contribute to this. The first is they get a classic post-viral fatigue illness, which is characterized by a number of things, but the two standouts are what I call energy-activated fatigue. Their ceiling comes down in terms of what they can do. If they push themselves, they pay for it. They get several days of significant fatigue and illness. Mm-hmm. And the second is they get brain fog or cognitive defects, if you want to be a little bit more precise, where, and we talked about examples the other day of this. So then we talked about a second set of symptoms which are due to more structural damage. And I think the interesting thing that's coming out of certainly the observations of patients I'm seeing is that there may be a closer parallel with a lot of these symptoms that I'm not sure, can people see the symptoms?
Yes, we can see the screen, yeah.
We can see what I can see, okay.
Yep.
Now, what I do with my patients, and some are better than others at doing this, but this is actually from a patient who is happy. I've asked if I can, without obviously mentioning his or her name.
It's a case study, isn't it?
It's a case study.
Yeah.
And now this is actually the data that the patient brought in to my clinic yesterday, actually. And what I've asked them to do is to take the symptoms that concern them and give a scale 0 to 5, where 0 would be fantastic, perfectly normal health. 5 would be incapacitated, they can't get out of bed, or as bad as they can imagine.
Yeah.
And then make up for each of them, take their symptoms and make up a scale that's relevant to them. And you can see this particular person, she put chest pain, passing out. The particular person had POTS syndrome, which many people would know about, where you're passing out all the time, you get autonomic nervous system involvement, a volume depletion of fluids in the body, and that comes together with postural hypertension, which means you stand up, you can faint.
Just remind us what that stands for, Robert.
Postural, orthostatic,
tachycardic.
Tachycardia.
Tachycardic syndrome, isn't it?
Yeah.
So in other words, when you stand up, your heart goes 90 to the dozen.
That's right.
And you feel dizzy and want to fall over again.
Dizzy and fall over. So what
horrible.
here is passing out, which was a big issue with this particular patient. Energy activated fatigue, and what they're calling cloudy brain fog, which I call cognitive impairment. And so you can see that.
So on the 13th of December, there were the 4 out of 5, 4 out of 5, 5 out of 5.
This particular patient,
they were really pretty ill, weren't they?
Extreme problems, completely unable to leave home, get up, go to university, all those sorts of things. Now, I think, have you got that graph that, again, this is a graph that was drawn by the patient.
This patient drew this graph,
Yeah, one of the general points I'd like to make is, I'll make 2 points. The first is that the interaction and working with the patient is part of the management team. And this just shows you the extraordinary value of having a relationship where the patient understands this and participates. Now, this is not a graph I've drawn. It's a graph from those figures that you've just seen. And you can see dramatic changes. Now, what you're seeing is a cluster of 4 lines. Each of those lines relate to the different symptoms that we went through in that table. Now, I can't remember. I think I gave them...
That's the chest pain, passing out, fatigue, cloudy brain fog.
So they're the classic symptoms of post-viral fatigue illness, plus chest pain, which you don't tend to get in people with Epstein-Barr virus. And I've always seen that as more a structural issue. And what is fascinating to me, or many things fascinating here, is that the symptoms all change more or less. This is a single patient, but a very important single patient observation. And what you've seen there is basically a complete remission, complete improvement. A person who was incapacitated to a person who was functioning pretty much normally after 5 or 6 weeks of taking this particular drug. Now, the idea was to then stop the drug and see what happened. And as you can see, there's essentially 10 days or so where there's a maintenance of complete remission. And then all the symptoms started coming back pretty much after a couple of weeks to where they were before.
All right. I'm going to stop here because it's not cool to play the whole thing. And besides, I want to leave this graph on the screen while I talk. So there's a problem here, folks. And that is the drug is ivermectin. Okay, by the way. And what this individual thing appears to show, I mean, this is, I've talked before about notch tests, okay, and that a notch test is one of the best ways to find out whether or not something actually does or doesn't impact you. Why? Because you change the thing, you see what happens, and then you change it back. You either stop doing what you were doing, or you start again doing what you stopped doing, and see whether or not the original problem returns. This is really, really useful when you're trying to eliminate things from your diet, find out, for example, what causes you distress or whatever have you. It is N equals 1. It is not a controlled study, but it gives you absolute information that you can use that is actionable for you. So, for example, as I've pointed out, I wear this Garmin thing, which is a wild-eyed bitch when it comes to ratting on you for going out and having a couple of beers. And because it gives you this overnight heart rate value, HRV. And I can take this thing and I can wear it. I can go 3-4 days without drinking anything, and then I'll go to the bar and I'll have a beer, and I can see the change in this. And then the next day I go back and I don't drink beer, and it goes right back where it was. I can have 2 beers, right? And I've worn one of these now for long enough that I can tell you with absolute certainty that certain things trigger this. Right? I can also tell you that fast carbohydrates, for me, n equals 1, have a similarly bad impact if I eat them during the day after about noon. Now, I never eat them in the morning, so I've not tried this at 8 a.m., right? Have a Hershey bar. Wouldn't really want a Hershey bar at 8 o'clock in the morning. But this is some of the best data you're ever going to find for you personally. And what troubles me about this is it says that ivermectin in this person did not fix anything. Didn't have any long-term impact at all. Everything went back, when they stopped, right back to where it was. But during the time they were using it, it was almost 100% effective. Now, that could be a placebo effect. It could be simply that they believed in it and therefore it worked. Maybe. But then maybe not. All right? I don't know. Now, if it is a placebo effect, then ivermectin did nothing, and it really is all in their head. Why? Because what's the other explanation, right? But the trouble I have here is that for the people that are selling these detox programs, the idea that you can do something and then stop and the problem will be gone, this data says maybe not. And I have a much larger issue with using something on a chronic, everyday kind of basis than I do with using it on a pulse basis, which is basically what's been done for 2 or 3 decades in sub-Saharan Africa. It's gotten rid of, essentially stopped river blindness. And it's also a malaria prophylaxis because that's a parasite as well. We have very good safety data on using ivermectin in that format. And it is safer than Tylenol or aspirin when used that way. And we have every reason to believe that that holds up under scrutiny because we've been doing it and that's been the results. We don't have that data for permanent use. And what this says is that it's possible that you can use it permanently, maybe to suppress symptoms if you don't build tolerance, if it doesn't wear out. There's a lot of ifs in there, right? But now you got a potential safety problem with using this stuff on a permanent basis. We don't have data on that. We don't know. I don't know that anybody's going to spend the money to find out either. And I'm a little bothered by that as well. So what I would say from what we have here is that I'm not real happy by seeing this graph. All right. For those people who are pushing this as a therapy for this particular problem, I'm all of a sudden unsold. I'll just leave it at that. I'm unsold, okay? Because what this now says is that maybe all we're getting is symptom suppression, much like Paxlovid suppresses COVID symptoms. Doesn't necessarily do anything for the virus in the longer term because it comes back in an awful lot of people when you stop using it. And for that, you take the risk of taking a drug that has a component in it that's in HIV drugs, which has a black box warning on it, by the way. And so I'm not real comfortable with quaffing that stuff. And this now says that unlike using ivermectin as a short-term intervention for an acute illness, you're sick, or on a prophylactic basis, once a month, once a week even, because there are an awful lot of folks that are using it on a weekly basis as prophylaxis in sub-Saharan Africa or monthly. Now you're talking about maybe using it daily on a permanent basis. And folks, that's trading one drug dependence for another. Remember, we've got data now that says that the COVID shots are that way. All right, that for a short period of time, they provide some benefit against hospitalization and death, and then after 3 or 4 months, it's zero. And by the way, it makes it more likely, negative 45% from this last study that I published some data on recently. And again, it's another study, okay? People don't like these studies. They certainly don't want to talk about the media, but this is actual study work, and it's over long-term follow-ups, and therefore you have to pay attention to it because this data does appear to be good. That says that it actually makes it more likely for you to get infected. Can't take the confounders out of that very easily, but boy, I don't want to take a drug that basically I have to go back every 3 months to get another shot, or it makes it more likely I'm going to get sick. Okay, and does that effect disappear over time? In other words, if I stop, am I more likely to get sick at 4 months, but after 6 months or a year, I'm back to where I started in terms of that risk? Or is that negative efficacy permanent? We don't know. And again, it's because the timelines that have been run so far don't give us enough information. Can't tell me what's going to happen in a year if you only do a study for 4 months. You have to do a study for a year. This data, though, suggests that you need to be a little bit careful with the idea that you can fix these problems with these so-called detox protocols. You might hide symptoms, you might suppress them, and then end up essentially in the same situation that people are with taking shots in the first place, which is that now you're a junkie, but now you're a junkie to something else. We don't know if there's a tolerance problem over time with these drugs. I know that a lot of people, for example, play around with antihistamines or seasonal allergies. I used to take them all the time. I had huge problems with tolerance. Interestingly enough, quercetin in myself does not have a tolerance response. Claritin does. So do all the others. Okay, so I mean, they all have different colors in the bottles. Well, guess what? Every single one of them, in me, maybe not in you, but in me, after a few weeks, they stop working if I take them on a daily basis for seasonal allergies. Fortunately, getting the carbs out of my diet has greatly attenuated those symptoms. And what's left, quercetin is able to deal with very effectively throughout the summer. I don't sound like I've got cotton balls shoved up my nose all the time. And I don't get tolerance response from that. But I'm concerned about the results of this study. And, this is N equals 1. It's one person. It's one presentation. But it's a very sharp response, folks. When you look at that graph, remember that these guys are not U.S. in the way they put out dates. Okay, so that 26/12/2023 to 2/1/2024 is not. 26 is obviously day, right? So the first one's obviously so it's in inverse order. So this is over a short period of time. So from the 2nd to the 7th. The 2nd was when you had complete remission for all intents and purposes on the 1st. And the 7th you had complete remission. And then 3 days later, you started to have a rebound in symptoms. Okay, so we were talking about a 7-day period, basically a week. And the rebound had begun. That is not what you want to see for something that actually is curative, as opposed to covering things up and papering them over. It's not the end of the story, I'm sure, but I think it's something that you ought to pay attention to. And certainly not the kind of result you'd want to see, and not the one that the people that are trumpeting this as a be-all, end-all would want you to see either. So, but is what it is, and that'll be it for today. I mean, Ticker guy.